Grand. So I think we'll just get started. So my name's Daniel Sherritt. I'm an assistant practitioner with the Hospital at Night team. And Catherine and the PEF team asked me to come and do an enrichment session to let you all know about the service, what we're all about, and how we work. If you've got any questions throughout, just let me know, and I'll answer along the way, or if there's anything at the end, that'd be grand. Okay, so the Hospital at Night concept was introduced in 2003, such a long time ago, when the Department of Health introduced the Working Time Directive, which cut junior doctors' hours from an average of 78 hours per week to 48 hours per week. And it's a multidisciplinary team approach, multi-speciality approach to delivering care at night time and out of hours with the aim of improving patient safety. It involves members of the medical and nursing staff coming together to form a team that manages patients across all disciplines in the hospital. Here at NCIC, we have the Hospital at Night team at the Cumberland Infirmary only. That's because the West Cumberland Hospital have ACPs and SHO doctors. So because of the number of junior doctors that we have at Carlisle, that's why we have the Hospital at Night team here. So I'll give you a brief history of the Hospital at Night team. So before 2020, there was a Hospital at Night service. It only consisted of 2 practitioners, and there was only 1 practitioner per shift. But because there was only 2, try to get annual leave in and sickness and stuff, sometimes there wasn't always cover. It was a bit sketchy with rotas and stuff at times. There was 1 F1 for all the surgical wards, 1 for all the medical wards, and if there was no Hospital at Night team, the junior doctors took on all the clinical tasks that Hospital at Night now do, which is quite a lot for them to manage. And with them being junior doctors, they needed to learn new skills and reflect on the practice and check in with seniors to make sure the patient management plans were correct, or if they had any questions. And there was sort of little or sometimes no opportunity to do that because they were so busy. And then that led to like a slow response for cannulas or for unwell patients. There wasn't really any sort of educational focus, which is a requirement for the F1s. And quite a lot of them were reporting that it was quite isolated and lonely. So they put in a complaint to Health Education England, which is effectively their educational body, and that's called the HENE, who's responsible for the junior doctor education and development. And then they put the trust under special measures, not under special measures, sorry, enhanced monitoring to address the issues. And since 2020, we've now developed the team quite substantially. We've got now 5 members currently of the Hospital at Night team. We should have 7, and there's a couple of posts out still for the team. We're always got 2 practitioners on per shift. 1 practitioner covers all the medical wards, the other practitioner covers all the surgical wards. In 2022, last year, we had 98% shift cover, which I think is fantastic. We've increased the doctor numbers of hours as well. So for surgery, there's 1 F1 plus 1 SHO, and for medicine, there's 1 F1 and 1 SHO, and then we've recently got a new twilight doctor that works from 4 till midnight, all for patient safety. We've got a shared workload, lots of opportunities for the F1s and for the Hospital at Night team to discuss patients with registrars, various levels of doctors. And there's also a very timely response by everybody that's working on a night shift and that really wasn't achievable before, but it more or less is now. And we try and incorporate lots of educational elements. We do some simulation training with the junior doctors in the hospital at night team. We've got better teamwork. We've got breaks for the doctors and for ourselves, which again wasn't happening before. We've got better handover processes, and we've got a thing called the safety huddle, which I'll speak about later on. We've got a monthly working group, which has foundation doctor representatives as well. If there's any issues, we can address them and see how we can improve. There's also quite a bit of clinical governance that goes on as well. Again, that wasn't really a focus before. We like to support lots of students, and I know some of the students on this call have been out with the team before. And really, patients get the right care at the right time. And we have really developed the team, and it's so much better for patients. And we kind of, because there's all these processes in, we kind of prevent deterioration, which is obviously a patient safety aspect as well. So we've undergone a complete transformation following significant improvements, and we were taken off the enhanced monitoring in June 2021 after positive recommendations and assessment of our performance. And the HENI, who are responsible for the doctors' training, are using our improvements as a model that other trusts can aspire to. So it just shows how much effort was put in, and like we've turned it around 360, and I think that we have really got a supportive team, and it's quite a bit safer out hours than it maybe once was a couple of years ago. So the hospital at night team members, we've got Ali Clark, she's the ACP in the team and she's the team lead. We've got Janine Mason, she's the senior nurse, and we've also got an ACP post that has just closed for advert, so hopefully we'll get another ACP in training soon. You've got myself, who's an assistant practitioner and the student lead. We've got Leslie Ann and Alex Welsh, who are the other assistant practitioners in the team. And again, we've just got one pending post for that hopefully will be filled shortly. We're also supported by management team. So we've got the emergency care matron at the moment is Rachel Easton, and we've got consultant lead for hospital at night, which is John Atkinson, and we've got general manager Claire Sinclair that helps us deal with the monthly meetings and improvements and all the business side of things. So the team's on a night shift. So the hospital at night team aren't just the practitioners, it's the whole team that's on a night time. So starting from the top, we've got the medical registrar, who's responsible for all the medical patients. That's supported by one medical F1 and one hospital at night practitioner. We've also got one LED or SHO, that's just a senior doctor for medicine. So that's on the medical side. Then we've got the surgical registrar for surgery, supported by a hospital at night practitioner and one F1, as well as one LED or SHO for surgery. And there's both medical and surgical consultants that are on call overnight. So the hospital at night team work back of house. So back of house is everything, all the patients that need to stay for specialist treatment. So that's all the wards and specialist units. Front of house is everybody coming in to the hospital. So that's places like A&E, AMU, Hazel Ward and ITU. So the hospital at night team predominantly work back of house. And we are also So extending the hospital at night team, we've got critical care outreach that support with deteriorating and poorly patients that may require ITU or people that have been stepped down from ITU onto the ward. We've got the site coordinators, also known as the bed managers, and we've got the biochemistry transfusion labs, which we work closely with. You've got your staff down in CT and X-ray, and security staff and ambulance crews. We attend handovers, which is a legal necessity. Can I get my words out? So the surgical handover is consultant led. It's down in the Learning Hub at 8 o'clock. We also attend a medicine handover in the Bates Resource Room, 8:30, and it's junior doctor to junior doctor. So on a night time, there might be things from the daytime that need to be reviewed overnight. If there's any outstanding clinical tasks that need to be done, will get handed over. So these are the sorts of things that we can get handed over. Deteriorated or unwell patients, hopefully the day team will have a plan in place, or they'll have had a senior review. If the patients only just became unwell before handover, they might ask the night doctors or the night registrars to see the patient for a senior review. Any patients that are end of life or that are expected to die overnight, we're usually made aware of them patients. Any urgent reviews or any falls that are outstanding. The hospital at night team will get clinical tasks such as bloods and cannulas, sometimes the odd NG that needs placed. And if there's any sort of issues with the computer systems or anything to do with the hospital, wards get closed, or there's been norovirus outbreak or anything, that's usually given a handover as well. And because we have a multidisciplinary team approach, we can discuss which jobs are necessary for the out of hours team, anything that can wait. This is just to sort of reduce the workload and make it manageable for the person or the teams managing overnight. So we've got the safety huddle. This is about keeping patients safe and on the crack. It's the Bates Resource Room 9:45 every single evening, and it's just a 5-10 minute briefing face to face, and we just speak about the patients that are most at risk or most unwell. We allocate cardiac arrest roles for those that are on the cardiac arrest team, so that if there was to be a cardiac arrest overnight, people on the team have a kind of predefined role, and it just makes the running of an arrest that wee bit smoother, we've felt. And then it's good because it's face to face and everybody knows who's working with each other. We know who the med reg is, we know who's on critical care, everybody knows, and it just makes that team working process a bit more easier. And as a team, we can talk about patients and we can sort of make management plans and problem solve from there. And again, if there's any issues with the hospital site, or there's anything going on, like maybe front of house, maybe A&E's really struggling for beds, or there's no beds, or maybe day surgery's been opened overnight, all them sorts of things we can talk about at the safety huddle. And it gives the opportunities for the junior doctors to speak with the senior clinicians, which again keeps patient safety, maintains patient safety. So what do we do as assistant practitioners with the hospital at night team? So we do predominantly cannulation, venipuncture, catheterization. Everybody in the team is trained to a minimum of immediate life support, ILS. The ACPs in the team are trained to ALS, so advanced life support, so they could, in theory, lead arrests if necessary. We are also, for any students that have been with us on the team, you'll probably see that we're quite a good advocate for patients and staff. I think patients find that because we're not based on the wards all the time, it's a fresh face. Sometimes patients can share quite a bit of information with us, tell us how they're feeling and things, and we can sort of pass that on to the nurse in charge, or writing notes and things. If a patient feels like they're not getting better, or that they've not had much communication from the medical team or whatever, we can just be an advocate for patients. We're on the cardiac arrest team when we attend the emergency calls. Hopefully it's not few and far between. The advanced nurse practitioners in the team, or the senior nurses, they can verify expected death and do ABGs, arterial blood gases. They can do false reviews. The ACPs in the team can do non-medical prescribing, NG and Riles insertions, and they are just a senior support to the nurse and staff if they have any questions. So just got to talk about clinical skills that we do. So this is where I want to hear your input, guys. So we do venipuncture. So any bloods that are taken out of ours, they need to be clinically appropriate. So can anybody tell me a couple of common blood tests that we might do out of ours, please? Don't be shy.
Troponin.
Yay! Thanks, Emily. Yeah. What does that look for?
If the patients had an MI, then you would be monitoring the troponin. Is that right? It peaks at 12 hours. I know that much.
Yeah, that's right. Yeah, if somebody's had a heart attack or an MI, usually their troponin would be raised. We would do one at the time, and then 1 6 hours later, and the difference will be more than 20%, usually if they've had an MI. Anybody else? No takers, right? So here's a couple of things. So your full blood count, and that looks at your HB, also known as hemoglobin, your white cell count, things like your platelets as well, and amongst all sorts of other things. Your U's a look at your urea and electrolytes, also known as sort of kidney function. That's looking at your sodium, potassium, urea. CRP is C-reactive protein, and that'll be raised if anybody has an infection. So your CRP should be less than 5, and sort of if it's sort of 50, 100, anything upwards of 400, you've got quite a good range of infection. It's quite a good infection marker. Your eGFR is estimated glomerate filtration rate, and it can give you an indication of how well a patient is hydrated or not. Going on to lactate is used for muscle breakdown and is quite a good indication of sepsis. You've got your coagulation screen, which is how well your blood clots. And a group and save is for anybody that is needing any blood components. So there could be pre-op if somebody's going for like a neck or femur surgery. They'll need a group and save because blood loss during surgery is quite common. If somebody is got a low HB and they're needing a blood transfusion, they'll need 2 lots of groups and saves. And it's just a cross match. Tells you what blood type they are and if they have any antibodies. And when we're doing venipuncture, we can use a single needle or butterfly needle in the hospital. Cannulation. Can anybody tell me common reasons to get a cannula in?
IV antibiotics or fluids.
Yep. Anything else? Come on, don't be shy. So yeah, so as Steph said, yeah, IV antibiotics, fluids, blood, theatre, CT contrast scans, PCA, which is patient-controlled analgesia, and TPN, which is nutrition that is done intravenously. Cannulas for that should be short-term only. So there's difficult cannulations might require ultrasound guided cannulation, where we ask anaesthetics or ITU to come with an ultrasound machine. If there's been sort of various failed attempts by different members of the team, say like the day team's tried, maybe 2 doctors in the day team's tried the vast hospital at night to have a look. We're unable to gain the access, so then we might ask ITU to come with the ultrasound and get it in that way. After any cannulation insertion, we need to fill the peripheral cannulation insertion document on WebV. That's really important. And I don't know if you're aware, but blood can be drawn from a cannula only on first insertion. This little device just goes on the end of the cannula here, and you can put your blood bottles in this this vacutainer when you put a cannula in, only for the first time, before it's flushed with any saline. All right, and so these are the different cannula sizes. The smallest one is the blue one. It's used, can be for patients with difficult IV access, maybe quite elderly patients that don't have the greatest of veins, and sometimes renal patients as well. Pink's the standard one that are used for most patients. So that's the one you'll probably see most often. And then green, grey and orange are classed as large bore cannulas. So these are for people requiring sort of rapid fluid resuscitation. We try and aim to put greens in if anybody's having like an upper GI bleed that might need sort of blood quite quickly. And greys and oranges are usually sort of pre-hospital or in theatre if somebody's really quite unwell, or A&E. We don't really tend to use oranges and greys back of house, just simply because it's not required. So the smaller the number, the larger the diameter. So the orange one's a 14 gauge, the G stands for gauge. It's a small number, the bigger the diameter. So the blue one's the smallest at 22 gauge. Can anybody tell me what the VIP score stands for? Oh, you're a shy bunch. So the VIP score is visual infusion phlebitis score. So if somebody's got a cannula in, we should be checking it at least daily and flushing it daily if it's still in use. If a cannula is not in use, i.e. there's nothing prescribed to use it, the cannula should be taken out. We should only be keeping cannulas in situ if we're actively using it. So this wee scoring system was from another trust and we've adopted it. So we should be looking and observing the cannula sites for any sort of redness, pain, swelling, just to make sure that it doesn't get infected and it's still in working order. So we should be scoring it every single day. Yeah, so yeah, it should be completed daily on the web feature. Cannulas can stay sighted for up to 14 days, providing that the VIP score is 0. If it's anything more than a 0, after 7 days, if it's anything more than 0 after 7 days, it should be removed. And yeah, if you're ever unsure whether a cannula is working or it's infiltrated or anything, just stop whatever you're using it and just seek advice from the hospital and night team or one of the junior doctors during the day or senior nurse. All right. Next thing we do as well, we can do blood cultures. So these are taken when there's a clinical reason to suspect bacteremia or sepsis. It's part of the sepsis 6 bundle along with a lactate, and it's 2 bottles. One is aerobic and the other one is anaerobic, and we should be trying to put 8 to 10 mils in each bottle. Sometimes that's quite difficult to gauge, but you're always better to put a wee bit too much than not enough in. So the labs test and grow it over 3 days and see if there's any growth of bacteria, fungi or yeast in the bloodstream. They'll do a report after each day, but it does take 3 days for a full report to come back, and it'll say whether it's resistant to any antibiotics and what they found in the bloodstream. Sometimes we get asked to do blood cultures quite a lot where it's maybe not clinically appropriate, and we should only be doing it if we are suspecting sepsis. So it says on the guidelines that clinical judgment is required. Okay. So the other thing I'll talk about as well is patient assessment and the ATE approach. Going around the hospital on a night time and seeing various patients that we do, some of them are quite unwell, and perhaps that the hospital and night team might be the first person to go and see a patient before maybe the doctors had a chance to, depending on what's going on. So we should be competent at doing an ATE assessment and sort of addressing or fixing any clinical problems as we go along. We'll talk about airway. So when we're assessing for airway, we're listening for any abnormal noises. If a patient's talking to you, then they've got a patent airway. If the patient's unresponsive or not rousable or not awake, we need to be checking their airway. So we're going to look at the position of the head, whether they're choking on anything, whether there's anything visible, foreign body, and you can do that by just simply looking in the mouth. If we suspect that somebody's airway is compromised or not patent, we can open the airway by using head tilt chin lift. And if needs be, we can suction it, and we can use airway adjuncts like a nasopharyngeal airway or an oropharyngeal airway, an eye gel, or then if a patient need intubated. Obviously that's way above our level and you'd be calling for help much sooner than that, but and we do them things to ensure that the patient has an open airway. So breathing, when we're assessing breathing for a patient, we're using the look, listen and feel approach. So, and it can be quite hard to do this in a night time because most of the patients that you're going to are asleep, or the majority of patients that you see in the night time are sleeping. So sometimes it just takes that couple of seconds when you go and see a patient, maybe just to look, listen and feel and actually make sure they're breathing and not just in a deep sleep or not breathing at all. We're looking at respiratory rate and effort. And if needs be, we can auscultate the chest to listen for breath sounds. And we're looking at the symmetry of the chest movements as well, whether you're getting bilateral movement of the chest. And And if needs be, we're looking at SpO2 as well, SATs probe. If somebody's oxygen saturations are quite low, we put them on oxygen, as long as it's above 95%, that is acceptable. Anything below that, we just pop a wee bit of oxygen on using the appropriate mask. And we're doing this to ensure sufficient oxygenation and ventilation throughout the body. So next we're going on to circulation. So we're looking at heart rate, blood pressure, capillary refill time. Just on the blood pressure thing, if you're using a machine and the machine's not picking it up, we need to be competent at doing manual blood pressures. So even if you're out on placement, it's good to get in the habit of doing a few manual blood pressures a week, just so that if you come to a situation where actually a patient is unwell and you are doing an AE assessment and you can't get a blood pressure on the machine, you should be expected to be competent at doing a manual blood pressure. We're looking at skin colour, and the doctors or the hospital night team or yourself as registered nurses can take blood samples and things to see what's going on. We'd also be looking for IV access at this time as well, if there was any sort of major concerns. And we could do fluids if somebody's BP's low, and this is all to stabilise circulation. We could also give blood as well if it was indicated, and there is a thing called the massive hemorrhage protocol, which can get rapid blood from the blood bank if somebody requires it. Then we're going on to disability. We're using AVPU, which is alert, voice, pain, or unresponsive. It's a very quick way of assessing the neurological state of a patient. You've also got the Glasgow Coma Scale, which is obviously a wee bit more advanced of the AVPU score. We're looking in eyes for pupils to see if they're equal and reactive to light. Really important as well, indeed, to do a BM. The patient can be unresponsive for quite a number of reasons, and quite a common one. It could be blood glucose levels. So it's really important to do blood glucose when we're looking at D. And a temperature as well in there that's actually not mentioned. We would do a temperature in there. And then down to E, oh no, you do the down to E, then you're doing exposure. So you're doing a full head to toe examination of the patient. Have they got any rashes? Have they got any swelling? You do a temperature in E actually, not D. You're looking for any injuries, scars, any signs of sort of drug abuse, or some patients can be quite crafty, so that's why the E exposure is quite important. And you're looking to do any sort of reversible causes, like getting the bear hugger on to bring the temperature up, things like that. And you're looking just for anything else that might cause whatever medical emergency it is. Now, by doing an AE approach on any patient that you come across, just gets you in the habit of using this approach, because when you need to use it and you've not really worked on it or done it before, is when you might struggle a wee bit. So it's good just to get in the habit. And I know students that are on this call have kind of used the AE approach before on patients that have been unwell, and in practice it works really good. And by addressing any issues that you come across in the AE approach, effectively you're preventing any deterioration or worse. So just a refresher of some emergency things. So can anybody tell me the number to put a cardiac arrest call out?
2222.
Cracking. And for a fire?
4444.
Oh, you've cracked it. Grand. And there is another number that you can use as well, is 4999. And that's just if you've got anything that's other than a cardiac arrest or a fire that you need sort of urgent attention. And it's usually fast bleep. So you can fast bleep a doctor or a registrar. You go through switchboard, and if a patient's quite unwell, but you don't need a full cardiac arrest team, but you do need a senior person there urgently, you can fast bleep, and the switchboard will just say who you need and where are they going. So that'll just come through the bleep, and it'll be, oh, can the medical registrar go to, say, Beach C immediately, please, medical emergency. And it just gets the doctors there fast. It can also be used for if there's any violence and aggression issue on the ward as well. That can be used for that. So I've got a scenario here for you. So we've got two jobs that come in at the same time. I need to know which one to go to first and why. So, being bleeped by medical ward, a patient is halfway through a blood transfusion as their hemoglobin was low and they were symptomatic. They require a cannula as the patient accidentally dislodged theirs. At the same time, a couple of minutes later, you were also bleeped by surgical ward. And a patient who's post-op after a laparotomy has spiked a temperature of 38.2 and has a heart rate of 93. It's scoring a news 2. What patient do you go to first? Do you think?
I'd say the first one.
You'd say what?
I would say the first one.
First one. Grand. Why do you think that is?
Because the surgical ward nurses can manage that for the time being, couldn't they? I don't know.
No,
and
it's fine.
it's important that the patient gets the blood.
Yeah. So blood can only be out of the transfusion lab for, I think it's up to 2 hours. So patient's halfway through this blood. So if they don't get a cannula promptly, that blood's going to, the time of that blood is going to run out and the blood might be discarded. Now, the patient on the surgical ward, has spiked a temperature. It's quite a low grade temperature. It's only just spiked and is a Muse 2. Now, it's actually 2/3 of post-op patients will spike a fever after a surgical procedure within the first 24 hours. So that's not really concerning at that point. If the patient was then to continue to spike multiple temperatures during the course of the next few hours and maybe their heart rate was to go up and they were musing higher, then that's fair enough. But I would certainly go to the blood transfusion first, given that the patient was symptomatic, hence why they were needing a blood transfusion. So their hemoglobin was quite low and they were getting a bit short of breath and a bit confused. So that patient really needed the blood transfusion. All right, I've got another one for you. So this is based on a scenario that just happened last week. So there was an elderly patient on one of the wards that was medically optimised. The nurses, whilst doing the rounds in the morning, about 5:30, 6 o'clock, went to see the patient. They were unwell and they'd done a set of obs. Patient was musing an 8. Okay, with MSATs. Note that the blood pressure was quite considerably low. Any ideas of what might be going on here?
Query sepsis, maybe?
Yeah. What would make you think that?
He's become unresponsive. He's only responsive to voice. And obviously, if you're scoring, is it 5 and above, you have to start the sepsis bundle anyway.
Yep.
But yeah, his obs are just all to pot, really.
Yeah. So we were thinking sepsis or a hospital acquired pneumonia. So what we done, so it was one of the F2 doctors and myself had arrived on the ward at the same time. The nurse was quite concerned about this patient, and I went to see the patient, and I don't know if you've heard of like end of bed. So you do your end of bed assessment, you just quickly look at the patient, and usually you can determine whether a patient's well or unwell, and this patient was quite unwell, so quite concerned, so it was quite important that we had to put things in place fast. So it was managed by myself and one of the F2 doctors. So as Steph says, we commenced the sepsis bundle. I inserted a cannula. We took bloods, including blood culture, lactate, FBCs and U&Es. He had a catheter in, but we changed it to a urometer, one of the plastic ones that measures the output a wee bit more accurately. The doctor put him on broad spectrum antibiotics to cover a hospital acquired pneumonia. We gave him a stat bag of fluids and put him on a strict fluid balance. Actually, the family were contacted and informed of the situation, and they actually came in and visited the patient because we thought the patient actually wasn't going to survive. But within 2 hours, he was alert, he was a news one, and it just highlights the importance of recognising the unwell patient and escalating it appropriately and fast. And it just shows you how quick a response that we now can give compared to a few years ago, and how we can just turn things around for patients. And that was quite a good job. It was quite a good job to attend and to sort it out. We were very fast in sorting the patient out, and it came to a very good result. So
you know what it was, Daniel? Sorry.
Yeah. So they did think it was sepsis caused by hospital acquired pneumonia. The patient had been medically optimised for about 3 or 4 weeks, and it also just highlights the importance of trying to get medically optimised patients out of the hospital. I know it's such a challenge at the moment, but yeah, these are the real effects it can have on patients. And the patient is still in the hospital, but he's much better than he was, and is doing well. Just wanted to speak about night shift working. Who's done nights before? Who's not done nights before? Because some of the students that come with us haven't done nights before, and it can be quite a big shock to the system. So just want to give you a couple of tips about night shift working. So try and get a decent amount of rest prior to the shift. Try and get a lie-in the morning or have an afternoon nap. Just have a lazy day on the day that you're starting a shift. Really important to keep hydrated before and during the shift, although it can be quite difficult if you're having quite a busy shift. Try not to have too much caffeine or energy drinks. It can be quite detrimental because you'll get the rise, but then you'll get a big fall after it as well. Always bring something to eat on shift, and try and ensure you have your breaks. So the future of the hospital at night. So we're thinking about introducing a task allocation system where there'll be a hospital at night coordinator, and all the tasks for the doctors and the hospital at night team will be distributed evenly by the coordinator. And that's something that we're thinking about introducing. You know, nothing's set in stone yet, but that's something that we're thinking about introducing. Now, the junior doctors feel that the weekend days are quite challenging due to the number of patients they need to see and the clinical tasks that are required. So there's also talk about hospital at night starting maybe a day service on the weekend. I think University of Cumbria are exploring virtual reality learning for students. And we've been approached to see if we could be part of that development. Somebody would wear a camera, probably me, and go around the hospital, and it'll give students the viewpoint of what happens on the night shift and things. Hopefully there'll be some increased ACP opportunities for development for our advanced clinical practitioners. We're on about doing some enhanced clinical skills for Band 4s and for the Band 7s. These things take a lot of time to get ratified and to get the processes in place. And obviously we want to develop and enrich student learning, and I think we're doing that quite well. We always like to have students with the hospital at night team, and it gives them a good flavour what goes on in the hospital. Sometimes we can have a really busy shift and be run off our feet, and other times it can be really boring because there's nothing going on. But yeah, it gives us the opportunity to talk about learning and learning needs, etc. So has anybody got any questions? If you want to join the team, anybody's welcome to join the team for a night or for a spoke placement. Feel free just to give me an email on my email address there. And if there's no questions, I'd just like to say thanks for listening. And here are some photos of students I've had.
Thank you.
No problem at all.
Thank you.
You're very welcome. Is that okay?